So our next gland is going to be the thyroid gland. And so we're going to talk about a few different things with the thyroid. We're going to talk about the different types of cells in the thyroid and what they produce. We'll talk about T3 and T4 and their roles and how those are made. We'll talk about calcitonin and what calcitonin's role is. And then we'll get into some different disorders that can occur with the thyroid, including underproduction, overproduction of hormones, so on and so forth, and talk about what those kind of lead to clinically. So let's first talk about what the thyroid is and where we find it. The thyroid is hanging out right alongside the trachea, just in front of it and just below the larynx, right? So it has this butterfly-like shape to it, where you see these lobes kind of reaching and branching out to the left and the right. And there's a couple different types of cells. We have follicular and parafollicular cells. So if we kind of take a look at the picture here, we can see them. We see here's the follicle, which is this kind of evenly colored space in the middle here. We see follicular cells kind of line that, so they kind of create like a circle here. And then the parafollicular are the ones next to it. They're kind of like the in-between. So follicular cells are going to be stimulated by thyroid stimulating hormone, and their job is to produce the T3 and T4. Again, T3 being triiodothyronine and T4 being thyroxine. You're, again, perfectly fine putting T3 and T4. If I spell it out, though, you should be able to recognize them. So these cells are going to be the ones producing T3, T4. And then we have this fluid, right, that's inside that follicle, right? So these follicular cells kind of create like almost like a bubble, right? And then inside that we have a fluid called colloid, and this is where we have thyroglobulin, which is going to be a protein. The parafollicular cells, they're going to respond to calcium ion levels, right? That's what their production kind of comes from. So when we have high calcium ion levels, then calcitonin is produced, and that is to help lower the blood calcium levels. So that's going to be part of our blood calcium level regulation, right? Homeostasis with there. So we see that they're called parafollicular because they are around, right, or next to the follicular cells. So anytime you see para, right, you think around or next to. So what's the purpose of T3 and T4, right? When we have higher amounts of T3 and T4, they are going to increase your basal metabolic rate, your baseline metabolism, right, is how we can kind of think of that. They are going to increase the synthesis of your sodium, potassium, APTAs. They are going to increase your body temperature. They're going to increase your protein synthesis levels. They're going to increase your use of glucose and fatty acids, overall increase your rate of cellular respiration, increase lipolysis, right? So we see basically that these guys are all going to turn things up, right? Overall, right, you're going to, with a higher level of T3, T4, they're going to increase basically how fast your body runs, if we kind of think of it that way. We're burning through, we're creating proteins, we're using fuel, right? We're going faster, right? It also is going to help promote development and growth of tissue like nervous tissue and bones. And you need these thyroid hormones in their proper amounts, especially when you're looking at early development for like a fetus and early childhood, especially when it comes to the nervous system. So T3 and T4, they're synthesized in that colloid, in that fluid like space, and the follicular cells that line that space. Now remember, T3 and T4 are lipid soluble, and if you remember the name, like triiodothyronine, iodo is in the name. So T3 and T4 rely on having access to iodine. Iodine is a key part, it's a key element in these hormones, in T3 and T4, right? So this is one of the reasons why we have iodine added to certain things like iodized salt, to ensure that you get enough iodine so that you can produce these hormones. So T3 and T4 are made from iodine as well as tyrosine to form thyroglobulin, or TGB. This is going to be just an inactive form so that we can store it and then we can activate it to release it later. Right, so here's our, if we're looking at like the picture of what's going on, we have iodide, so just iodine ions that have been trapped from the blood and pulled in. We then produce that TGB, the thyroglobulin. We secrete it into the space, right, into the colloid space in the follicle. From there, we oxidize the iodide. So we're going to we're going to pull away that electrons. We go from I negative to I neutral, right? We are going to add it to our tyrosine. Going to couple it with T1 and T2, and then we can bring this back in, break down the colloid, right, that fluid, and then release T3, T4 into the bloodstream, right? So this is kind of what we're doing. If you're trying to, follow along here, right, what are we doing to kind of produce and store and release these hormones? So I would generally be pretty happy if you have a basic understanding of this process, and in the very least remember what cells and what parts of the thyroid are responsible for synthesizing and storing T3 and T4. Now, we need a signal though to tell us to make T3 and T4. And this again starts at the very top. It's going to start at the hypothalamus. The hypothalamus is going to release thyrotropin releasing hormone, or TRH. This is going to tell the anterior pituitary to release thyroid stimulating hormone. And then thyroid stimulating hormone will stimulate the thyroid to produce T3 and T4. So why would we want to stimulate more T3 and T4? It could be because T3 and T4 levels are low in the blood. It could be because we need to increase ATP. There's an increased demand, and so we need more thyroid hormones so that we can go through and kind of you go through glycolysis, go through lipolysis, right? So that we can produce more ATP. And then at the very end, when we have enough, T3 can actually inhibit both the anterior pituitary and the hypothalamus hormones. So let's take a look at kind of what's going on in the picture here and talk ourselves through it. So in this case, we're starting off T3 and T4 is low, or our metabolic rate's low. And so that's going to be picked up by the hypothalamus. Hey, these levels are low. So the hypothalamus senses this, right? We then release TRH. TRH is received by the anterior pituitary, right, through the portal veins. This is going to stimulate the anterior pituitary to release TSH by the thyrotrophs. That gets into the bloodstream. It stimulates, TSH stimulates the thyroid, right, in the follicular cells. The follicular cells release T3 and T4. And then once our levels are back up to a good level where we don't need any more produced, then T3 will stop TSH and TRH at the anterior pituitary and hypothalamus levels. Again, negative feedback, so that we're not constantly putting out hormones, right? So if you remember early in the semester, I talked about stocking the shelves, right? And that once you've stocked the shelves, you need to, you want to stop putting things out and put those things away in storage. And that only when the shelves get low again are you going to restock them. Same kind of thing. We have T3 acting as our signal of the shelves are stocked. We have enough T3. We don't need any more out. For the time being, stop stocking the shelves, right? Tell your boss that you've already put everything out that can fit. The other hormone that the thyroid is responsible for is calcitonin, and this is going to be from the parafollicular cells, so different cells, and it's going to be for a completely different process. So we remember T3, T4 are responsible for like your metabolism. Calcitonin, as the name implies, is going to deal with calcium, right? Calcitonin, calcium. When your blood calcium is high, calcitonin is going to help reduce that level. right? So I like to think of it as calcitonin puts calcium in the bones, is the way I try to remember it. But calcitonin is going to lower blood calcium. It's going to allow the bones to bank that calcium away. So it's going to stimulate the production of bone, especially bone matrix that uses up that calcium. It's going to slow or inhibit the breakdown of bone. It's also going to tell the kidneys, hey, any extra calcium, just get rid of it, right? Just excrete it out. And when it comes to the intestines, right, again, if we already have enough, it's going to tell the small intestines, you don't need to absorb that calcium, right? Just let it go, right? So we can store things away in the bones, right? Store that calcium away in the bones. But if even then there's just too much, we can excrete it in the urine, right, via the kidneys, or we can just never absorb it from the food we eat in the first place. But sometimes things go wrong with the thyroid. So there's a few different disorders. One is hypothyroidism. This is where our metabolic rate is too low. We are not producing the proper amount of T3 and T4. These levels are too low. And so this is everything you think of if you were not doing much or your metabolic rate was low is going to happen. So someone with hypothyroidism, right, with a low metabolic rate is going to feel tired. They're going to feel, not even just tired, they're going to feel like exhausted. They're not going to do well with stress in the form of cold, right? So cold temperatures will be very upsetting. This person will have trouble with weight gain. Even though they're not eating a lot, right? They might be going to the gym and exercising. They may be eating right and everything, but they're still gaining weight. Even though they're, doing all these textbook good things, right, in terms of maintaining weight, but because their metabolism has been brought down so low, even a normal diet, even exercise is not enough to stop weight gain. There's a few things that can cause this. There's an iodine deficiency. Because iodine is a key element in T3 and T4 production, too little iodine can impact how much T3 and T4 you're able to make. In fact, it will, if you don't have enough iodine, your thyroid will actually overgrow to try to compensate, to try to capture and make, capture as much iodine and make as much T3 and T4 as possible. That swelling, that overgrowth is called a goiter. We see that here, this person's throat. Their thyroid is absolutely massive. In our society here in the US, I can't speak for other places in the world, but in the US, we really don't see this happen too much because iodine has been added to a lot of things that we typically eat. So for example, salt, the table salt that you just get, typically is iodized salt. So it has iodine added to it. Other foods too are fortified with things like iodine so that you can get enough in your diet to avoid that. Myxedema is when you have a problem with your thyroid later in adulthood. So basically your thyroid starts underproducing for whatever reason. It starts underproducing the hormones, and so that's where we would see things like being tired, the cold stress being problematic, the weight gain being problematic, as well as issues with the skin and like accumulation of fluids in the subcutaneous layers. And then congenital hypothyroidism, this is where we're looking at during fetal or infancy development, right? We're looking at fetal development, we're looking at the early infancy times, and this is where the thyroid is not producing enough. Then remember that this is very important, that the thyroids and T3 and T4 are very important when it comes to proper nervous system development. And so having hypothyroidism that occurs this early is going to have, cause problems with growth, but it's also going to cause problems with things like cognitive impairment, things like seizures and whatnot can develop with someone with congenital hypothyroidism. There's also sick euthyroid syndrome. Basically, the host mechanism, it represents the basic host mechanism to conserve energy when you are undergoing physiological stress. And so when we see people who are like critically ill and hospitalized, we see that their T3 and T4 levels go down, but they're still producing normal thyroid stimulating hormones. And so this can be, you know, when someone's in like going through a really, I guess we say, medically traumatic kind of time in their life, this can develop. So like if they're in the hospital for pneumonia, or they have like a severe infection or sepsis, they went through some sort of major trauma, some sort of organ failure, right? Something like that. We can see something very similar, you know, that kind of mimics hypothyroidism, right? Because of the physiological stress. Now, I'm not as worried about this one as I am things like the iodine deficiency and myxedemia. Those are the ones I would worry about more for something like a test. Now, you can also overreact as a thyroid. This is called Graves' disease or hyperthyroidism. This is where your metabolic rate is too high. This at first can sound appealing because a person with hyperthyroidism at first may feel really energized. They don't really need to sleep that much, right? They're doing great. They're maybe losing weight. They feel like they can eat more without having the fear of gaining that weight. Fantastic, right? But it continues to progress to the point where that person now is sensitive to heat because they're basically overheating. Remember that the thyroid's actions lead to an increase in body temperature, right? An increase in chemical reactions. And we know when we increase metabolic rate and increase the number of chemical reactions, they all release heat. And so someone with hyperthyroidism would be very sensitive to heat. They would experience weight loss that they were not trying for, which sounds good for anyone who's trying to lose weight, but this can be to the point where that person is not able to maintain a healthy weight, right? They're losing more weight than they should. This person may feel very like hyperactive. They may be anxious. They may have insomnia now. They'll get irritable. So it sounds like when you start describing things, some people are like, wow, I wish I would get that. But in reality, this progresses and can really disrupt someone's life to the point where they have problems with their weight, problems with not being able to sleep, problems with anxiety, problems with irritability, because, I mean, think about being sleep deprived. They're still going to want to sleep, but they can't sleep very well. And so all the things that come with sleep deprivation also come with this on top of it, the sensitivity and the weight loss and whatnot. There's also a risk for something called a thyroid storm, which is a sudden release. That is a medical emergency where you have this massive over-release. It absolutely requires a trip to the emergency room. That is life-threatening. Why do people have hyperthyroidism? Sometimes it can be an autoimmune disorder where the antibodies bind to the receptors for TSH and basically mimic, right? Your immune system almost like accidentally turns the thyroid on, right? And then so we see some things like changes in like the pressure in the eyes. So we see like bulging eyes, and sometimes it's one, sometimes it's both that can bulge out. That's a classic sign of Graves' disease when you have that bulging of the eyes. Other things that can cause hyperthyroidism can be something like cancers or tumors, right? That lead to that overproduction, that overactivity on top of that.